Thomas Baldrick here at the 2014 ASH Conference in San Francisco. Happy to have with us from Mount Sinai in New York, Dr. Louis Silverman, talking about the relationship of bone marrow blast and survival. Thank you, sir, for stopping by.
Thank you very much for having me.
Tell us first about this study, and then we can get into some particulars.
Okay. So this study is an analysis of a subset of patients from a randomized phase 3 trial that compared treatment with Rigosertib, an investigational drug being tested in patients with Myelodysplastic syndrome, compared to patients who received best supportive care. In that group, received blood transfusions, antibiotics, or they could have received low-dose cytarabine as well as part of their treatment. So the patients were broken up into these two groups, and we did an analysis of the effect of treatment on bone marrow response at two time periods. One is the 4-week time period and 12 weeks after the start of treatment. And we did an assessment of the bone marrow blast percentage in the marrow at those two time points. This was based on prior observations in earlier studies where we had identified that either a reduction or stabilization of the bone marrow blasts correlated with improved survival. These were small, earlier phase studies, and so we weren't sure in a larger population whether these time points would in fact correlate with survival in a bigger population. So in this phase 3 study, which included almost 300 patients, we were able to do this analysis in these two groups of patients.
Can you talk about the importance of searching for an endpoint and doing it in a timely manner?
Right. So survival has been the accepted standard, the gold standard by which drugs are measured, assessed, and ultimately approved by regulatory agencies. And whether it's overall survival or progression-free survival, those endpoints have been the predominant way of measuring impact of a drug. There have been other drugs that have been approved on other bases, but that's by and large the majority of drugs, and at least in oncology. And there's a terminology called intermediate clinical endpoints that is now being assessed by the regulatory agencies to determine if a drug can demonstrate that there is a biologic effect, whether it's on response or whether it's on the basis of a molecularly defined patient population, whether there is such a marker that correlates with survival, that the regulatory agencies will consider approval of a drug on the basis of demonstration that this marker meets the criteria for an intermediate clinical endpoint. The advantage of that is that using that kind of intermediate clinical endpoint, could approve a drug at an earlier stage in a trial without having to wait to demonstrate a survival benefit at the completion of a trial, because usually the trial completes and then you have to wait 6 months, a year and a half, 2 years more for data to come in to demonstrate the survival differences between the various populations and the various treatment interventions. So this is an important way of trying to make a determination that a drug has efficacy, is beneficial for patients, do it earlier in the course of development, and therefore allow a drug to be approved sooner, and therefore the drug can get out to the community and the patient population that it will benefit sooner in the course of development. So it's an important aspect of drug development.
What do you do next with this? I know you feel this work is significant. You're trying to create positive change, trying to listen and follow what the FDA is saying. There's lots of implications here.
Well, there are. In this study, we did find that reduction or stabilization of the bone marrow blasts at 4 and 12 weeks was correlated with survival in a statistically significant manner. And And so it does suggest that this reduction or stabilization of bone marrow blasts will meet criteria as an intermediate clinical endpoint. And so really one of the next steps would be to look at this not just in studies with Rigosertib, which is where this analysis was done, but potentially to look at other trials as well. There certainly is precedence for this. We've shown, for instance, that azacitidine in patients with myelodysplastic syndromes, that patients that respond to azacitidine treatment have a positive correlation with survival. And compared to non-responding patients, the patients have an extended and significantly better survival. So in essence, there is precedence in the world of MDS that there are intermediate clinical endpoints that correlate with survival. And azacitidine originally was approved on the basis of response. Now, in that original study, it wasn't clear whether a response would correlate with survival. Nevertheless, because there were no drugs available, azacitidine was approved based on response. And in a subsequent phase 3 study, it was shown that response did correlate with survival. So there's precedence in the world of MDS and the treatments of MDS that there are surrogate intermediate clinical endpoints that correlate with survival and can be beneficial. And I think overall, really the significance is to help identify drugs that will have a meaningful impact on patients and correlate with benefit for patients, and therefore allow drug development to proceed more rapidly and get drugs out to the MDS population more quickly. And that's important because there hasn't been a new drug approved in the world of MDS for over 8 years. So,
Good luck in your race against time. We appreciate you spending your time with us.
thank you very much for having me. Okay, thank you.